In this next science session, the focus will be on post-exertional symptom exacerbation. By the time this session is over, you will be able to better understand the symptom presentation, pathophysiology, assessments, and safe rehabilitation approaches of post-exertional symptom exacerbation. This format will be presentation followed by a panel discussion. Our presenter from the Department of Physical Therapy, University of the Pacific in Stockton, California, and long COVID physio education co-director in the U.S., Professor Todd Davenport. Todd, welcome to the forum.
Hi, everyone. Thanks for having me. When we first designed this talk, it was intended to be a science talk related to post-exertional symptom exacerbation, in which we are going to go over some of the data and evidence related to PESE, and then follow with a panel discussion with my illustrious panel members. And so if we're doing this right, I'm not doing most of the talking. So I'll start, lead off, and then just can't wait to ask questions of our panel. So without further ado, let's get started. So why we're all here is surrounding the patient experience that the World Health Organization attempted to capture in a case definition what seems like forever ago, and a case definition that hasn't been updated and probably needs to be updated with the emergence of different variants. But a history of probable or confirmed SARS-CoV-2 infection about 3 months from the onset of COVID-19 for symptoms that last at least 2 months and can't be explained by an alternative diagnosis. And I'll point out that under the lived experience of long COVID are probably at least 5 different categories of pathophysiology, everything from post-intensive care syndrome, end organ damage, the iatrogenic effects of other types of treatments, post-viral deconditioning. But where I want to focus today is what seems to be the emerging kind of consensus on the long COVID presentation of this metabolic, neuroimmune, cardiovascular, and autonomic dysregulation that we heard a little bit about in the previous sessions. I'd like to go back to the international consensus criteria for myalgic encephalomyelitis chronic fatigue syndrome, which has been my research and clinical experience over the past dozen years, because I think that's where we're borrowing PESE. And so the criteria, the ICC criteria for PENE are here on the screen. And post-exertional symptom exacerbation is one component of it. But it's this marked rapid physical or cognitive fatigability in response to exertion. And that exertion doesn't have to be anything elaborate. It can be, as the patients here will tell you, something simple. It may be as simple as showering. It may be as simple as chopping vegetables to prepare a meal. And so it can trigger, again, symptoms that last, disablement that lasts hours, days, or even weeks, sometimes months. The recovery period is often prolonged, and that there tends to be a relatively kind of this relative spiraling cycle of decline of physical and mental fatigability that results in substantial reduction in activity compared to pre-illness levels, which you commonly also hear from our patients. So the characteristics of PESE aren't just fatigue. This isn't just tired. When I introduce my research area to lay people, they go, "Oh, I'm so glad that you're studying tired. Man, I get tired sometimes too." It's like, nope, that's not it. This is bonked. This is the feeling of nothing left. This is the choice is to lift your head. Is the type of metabolic expenditure that's very difficult when you're in an exacerbated or a crash state. But it's not just fatigue, as we'll see in the next slides. It's breathing problems, it's cognitive dysfunction, attention and short-term memory issues that we commonly sort of hear of as brain fog. It's dizziness, it's migrainous headaches, it's lightheadedness and dizziness, pains, nausea, problems with digestion, and also symptoms and signs sometimes associated with viral reactivation, sore throat, swollen lymph nodes. So you commonly hear from folks who are in a crashed state, "Man, I feel like I got COVID again, but I took a COVID test and I don't have COVID, but I feel like I have it all over again." Some excellent research has come out from patients who have turned their finite energy but their lasting curiosity and their advocacy inward to understand what's happening to be able to communicate. And so very well done survey that was completed by the Patient-Led Research Collaborative, PLRC, identified 3 important clusters of symptoms. And so the first cluster really is kind of indicative of the acute SARS-CoV-2 infection, which tends to kind of decrease in frequency over time. The second is more of a kind of a neuropsychiatric cluster with pulmonary issues. But it's this third cluster that really piqued my interest as someone who's been studying post-exertional malaise or post-exertional symptom exacerbation for a while, because that's the one that becomes more frequent over time. So we definitely see this as being a prominent feature of prolonged symptoms and disablement following a SARS-CoV-2 infection. More recently, kind of hot off the presses, is this article by Klein and colleagues where they looked at 215 people and did some really deep phenotyping work, looking at the clinical presentation, looking at disablement, looking at immune typing, immune profiling. And what I want to point out on the left-hand side of the screen there in G are all of the symptoms that are prevalent in over half of the subjects. So very in that shaded box there are ones that clinicians really should be sort of listening out for: weakness and confusion, dyspnea, difficulty sleeping, dizziness, difficulty remembering things, headaches, dysautonomia, so racing heart rates and inappropriate heart rates and palpitations, again, brain fog and fatigue, but also look at the tail of all the different types of symptoms. So understanding that a patient's symptom presentation is personal, and everyone has a different symptom experience, and that clinicians should be ready to ask questions and be supportively curious about that. And then on the right side, just noticing the pervasive disablement that people with long COVID report compared to people who are recovering from COVID, and compared to people who have not had COVID, healthy controls. I do want to point out that there are a few depression inventories and so forth, looking into the incidence of depression. This is more of a reactive depression. If you look at the symptoms on the left, imagine living with those and being functionally disabled by those, reducing your participation with family and intimate partner relationships and work. And so forth, and imagine not being depressed about that. So I want to point out that as we'll see in the next slides, even though we do see anxiety and depression being present in people with long COVID, that is not the pathogenesis. Much of what we know about post-exertional symptom exacerbation comes from exercise testing. And basically doing open-ended questionnaires following exercise tests. And so I do want to introduce the Stevens protocol, which was developed by my colleagues at the Workwell Foundation, in which we do a battery of pre-tests, paper tests. We do EEGs, look at resting EKGs, and then do a first maximal cardiopulmonary exercise test in order to basically induce the post-exertional state using a standardized physical stressor. And then in the second test, we can actually measure the physiology of the post-exertional state when people are symptomatic. So that's basically how this works. And so anytime you see a 2-day or a test-retest cardiopulmonary exercise test protocol, that's what you're seeing. Before my time with the Workwell Foundation, my colleagues published a paper looking into symptom responses following the 2-day CPET, and what they found was that in people who were sedentary, so deconditioned age and sex matched control subjects, fatigue was very common immediately after getting off the exercise bike. Muscle and joint pain also was common, and then followed by things like headaches and nausea and weakness. And if you've done a maximal cardiopulmonary exercise test, this is not a surprise to you. That's what it's designed to do. Now, the next day, our healthy but deconditioned control subjects largely were doing fine, and by 1 week, we had very low self-reported symptoms. But if you look at folks who met the Fukuda criteria for myalgic encephalomyelitis chronic fatigue syndrome, not only did you see the fatigue and, some of the muscle and joint pain and the weakness and so forth, but you also saw things like lightheadedness, you saw cognitive dysfunction, you saw nausea, you saw an increase in the presence of nausea, and also sore throat and swollen glands. And instead of getting better over time, the folks with ME/CFS got either stayed the same in terms of fatigue, even a week out, or some of the symptoms amplified. They got worse in terms of muscle and joint pain, in terms of cognitive dysfunction, and in terms of headaches. And over here, you see sore throat and swollen glands becoming more frequent over time, as well as insomnia. So more unusual symptoms got worse over time and were more persistent. So within 24 hours, our sedentary control subjects generally will recover from a cardiopulmonary exercise test, in contrast to 0% of people living with post-exertional symptom exacerbation, in this case, ME/CFS, and the remaining 15% of control subjects will recover within 48 hours. But it's notable in this study that only one subject with ME/CFS living with PESE recovered within 48 hours. So again, looking at an abnormal response to recovery response to exercise. Dr. Lily Chu and her colleagues did an internet survey, which is very, very well constructed, looking into basically what does post-exertional malaise look like? What is that lived experience? And you can see on the screen, again, a whole host of symptoms that are just very commonly experienced, and experienced more commonly with physical and cognitive exertion, not emotional distress. So again, providing some indirect evidence that underlying mood disorders do not factor into the pathogenesis here. But again, appreciating how many symptoms there are and how frequent they are. How long does it take between an exacerbating event and the onset of post-exertional malaise? Well, in some folks, it's immediate, and maybe another subset of folks, it's between an hour to 24 hours later, but the rule is that it can vary. So again, as clinicians, we need to be sensitive to not only the number and symptom experience and severity of symptoms, but also start to help tease apart onset latencies. How long does it last? Which is a really common question that patients ask. In this survey, 3 days to a week was kind of the most common. With 1 hour to 2 days is kind of in there too. But again, the plurality of folks said that it can vary. So we really need to be sensitive to individual differences in PESE presentation. So for the clinicians there, we have some evidence-based screening to questions that we can ask, again, asking how long does it take to recover, asking about some specific symptoms that have some basis in the evidence in terms of being able to identify quickly whether a person has post-exertional symptom exacerbation. There are other tools like the DePaul symptom questionnaire, especially the post-exertional malaise subscale can be very helpful as a discriminative tool as well. I'm going to really briefly summarize what we know about the physiology of PESE, mainly again from exercise testing, but I'm going to introduce an analogy that the bioenergetic pathways that humans use to sort of fuel their activities are a lot like the fuel sources of a hybrid car. You have the long-term sort of high torque energy system, which is like the gas motor. This is your aerobic energy system. This kicks in later to pay back your short-term energy system. And is normally very rich with energy, using fats and sugars and burning them in the presence of oxygen. And then you have your short-term local energy storages in the muscles. And this is like the battery. And so in people with PEM or PESE, the gas motor is unreliable or dysfunctional. It's not there for those longer-term types of activities. It's not there to charge up the short-term energy system, the battery. And so if you keep this analogy in mind, I think the rest of it makes a little bit more sense. There's a nice systematic review that just came out actually of the exercise physiology findings related to volume of oxygen consumed and workload. But this is a study that was done by our group looking into the amount of oxygen you're utilizing and the workload that you're exerting on a cardiopulmonary exercise task using a 2-day cardiopulmonary exercise test. And essentially what we found was that at ventilatory anaerobic threshold, which is the kind of transition point between using your short-term energy storage and your long-term energy system, there is a reduced volume of oxygen that we consume, meaning that we have noticed a decrease in the physiological ceiling for people to be able to do function. And so we think this has a lot to do with why people become symptomatic and have the disablement that they present with in the post-exertional state. Literally, the physiology is different, and that we can actually accurately predict folks who have declines using the criteria of a decline in VO2 and workload at this transition point will correctly classify 95% of patients who are living with post-exertional malaise or post-exertional symptom exacerbation. We also have a little bit of evidence also from invasive cardiopulmonary exercise testing. This is a single test that's done in a cardiac catheterization lab where sensors basically are threaded into the heart to measure pressures and gas composition of the blood and the different sides of the heart. And just there's one study using a mild disease cohort that didn't necessarily include post-exertional malaise, but found a decrease in oxygen consumption at ventilatory anaerobic threshold and peak exertion compared to control. So very similar to what we found on two tests, as well as an exaggerated hyperventilatory response, which is a pulmonary breathing dysfunction, and most notably impaired systemic oxygen extraction, meaning that the oxygen is there, it gets in through the lungs into the blood, but is not being taken up in the cells. And so it tends to return to the heart. The blood that comes back to the heart is more oxygen rich. And it's very, very analogous to similar studies that were done in MECFS. So adding to the observation of low systemic oxygen extraction, low cardiac output, and decreased filling pressures, which may suggest decrease in plasma volume and autonomic dysfunction. Also, a few very complex studies in metabolomics. Metabolomics essentially are a series of body fluid draws and an analysis and sort of deep phenotyping of the disease using those tools. And just a very 30,000-foot flyby in the cerebral spinal fluid, in the urine, and in whole blood, there is evidence for predominance of anaerobic metabolism, meaning that people are living in anaerobic metabolism, which makes sense because if your glycolysis is inhibited, if your ability to use your aerobic energy system is inhibited, you are going to use your anaerobic system more. And so we do see evidence of reduced aerobic metabolism. We see evidence of increase in anaerobic metabolism. And then also, probably as a result of living in anaerobic metabolism, oxidative stress and neuroinflammation we see in people living with PEM and PESE. So I've totally lost track of time here, but I wanted to make sure that we left plenty of time for discussion with our panel. And so I want to just throw out to my panel members just the chance to quickly introduce yourselves, if you would, please. And then I can't wait to ask you questions. And I'll also keep an eye on the chat to see sort of what may be coming up there as well.
Hi, everyone. My name is Alyssa. I am in Western Canada, about 40 minutes from the Rocky Mountains in Calgary. I'm a person living with long COVID and also have since been diagnosed with myalgic encephalomyelitis and POTS. Oh, and I'm a physiotherapist.
Hi, my name is Hannah. I live in Ottawa, Ontario, Canada. I'm a person with long COVID, and I'm a co-founder at the Patient-Led Research Collaborative. I'm a patient researcher.
Shall I go next? Hi, my name is Margaret O'Hara. I live in Birmingham, England, and I'm a person with long COVID. I'm a co-founder of Long COVID Support, which is a charity based in England and Wales, which, well, does what it says on the tin, offers support to people. I do a bit of patient-led research as well, and I my particular type of long COVID is relapsing and remitting and recurring. So I'm on my third bout of long COVID at the moment, and I'm a bit crashy at the moment, to be honest. So this is the session for me if it's all about PEM, because that's kind of what I'm feeling at the moment.
Hi, I'm Melinda Maxwell. I'm in North Carolina in the United States. I'm a PT and I have MECFS. I'm the co-founder of a Facebook group that we'd love for any of you to join. We initially formed it, my co-founder, Sally Radisky, and I. It's PT/OT resources for treating MECFS. We formed it shortly before the pandemic, and now we've expanded it to include resources for treating long COVID as well.
And hi, everyone. Hopefully you can hear me. I had some audio issues there. I'm Lauren Singh. I'm a physical therapist and the clinical lead for Alberta Health Services post-COVID rehab program based out of Calgary, Alberta, where Alyssa also is.
Well, thank you all for joining. And I have one big question for each of you. And that really is, what is the post-exertional symptom exacerbation experience like for you? Margaret, can we start with you?
Yeah, this is real-time information. I feel like a rag doll that's been run over by a bus. So limp, tired, with this feeling at the front of my head, which is a bit throbby. I'm a bit trembly, and I just generally feel like I want to go and lie down. So that's mostly what it is for me.
Well, thank you for joining us, and make sure to take care. Melinda, how about for you?
It's like, for me, it's like hitting a brick wall. There's just nothing left to draw from, as opposed to someone who's tired. They can dig a little deeper and get it going. But for me, when I've hit that wall, I'm headed to the bed.
Thank you. And Hannah, how about for you?
For me, it's been unpredictability. I was a semi-competitive athlete before this, and I was also very adamant about tracking my own energy levels and heart rate variation, doing some heart rate training, and with post-exertional malaise. And I see some of this also in the chat as well, that for those of us who have been athletes, it's just been very unpredictable in terms of how much energy I can afford to spend, not only just throughout the day, but the day after and a day after that. So for me, it's been very hard to plan my life around.
Yeah, thank you. Lauren, how about for you?
I suppose I come at it from a different lens because I'm not living with long COVID or experiencing post-exertional symptom exacerbation, but from a clinical lens, and having this be the bulk of the population that we're currently serving, it's a real challenge, and it's super humbling as a clinician to come from a place of needing to trust your patients, because you don't have any real good evidence, and you have to unlearn and relearn what it means to be a physical therapist and what rehabilitation is going to look like. And then it simultaneously really highlights that piece of being a clinician and trying to be an advocate for your patient by communicating to combat, society and other healthcare providers' understanding of what rehabilitation or what expectations your trajectories for recovery looks like.
Yeah, absolutely. Thank you. And Alyssa, how about for you?
Yeah, I think I could easily echo everything that's been said, but it's a cluster of symptoms. It's not just fatigue, but the fatigue is intense, unlike anything else that I've experienced in my life. And I also find just the interesting intersection for myself personally as a physiotherapist, and having to unlearn the deconditioning lens and how that framework does not apply here. Like I spent my 10-year career working in acute care hospitals and specifically in neuro rehab. And even though there's a strong neurological presentation with these illnesses, it doesn't mean that I have a bunch of skills that necessarily automatically apply. There's still that unlearning of the idea of linear progression and that recovery will happen And that's not necessarily true for everybody. Some people will recover and some won't be able to. Now, as myself, like also living with this illness, I still can call myself a physiotherapist, but I have been unable to return to work. For me, PESE, the biggest piece, like it is the most disabling feature of this illness for myself, and especially the cognitive stamina. And so how that translates into life is the trade-offs that are necessary, the flexibility and adaptation that are necessary in every part of life. And if I am able someday to work in some capacity, the trade-offs that will require in order to work are huge and tremendous. So that's the thing that I think about a lot. The fact that I am able to take the time to learn how to pace is also a privilege that a lot of people don't have. A lot of people are having to just work until their bodies literally won't let them anymore. And so that's a really big piece of this too that comes to mind.
Yeah, thank you. Thank you for that comment. Thank you, panel. And in the interest of time, I think we'll go ahead and move on from here. But I really appreciate your time and your insight. And thank you to, I've been watching the chat. The chat is just, it's been great. And I wish we had the entire day to be able to go over and discuss these themes. But we will, in the interest of time, move on. Thanks again.